Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of non-accidental trauma in pediatrics, covering clinical assessment and management for general pediatric physicians. We will work through carefully constructed clinical cases covering the full scope of this critical topic, including suspicious bruising patterns and skin injuries, skeletal red flags, ocular findings, abusive head trauma biomechanics, imaging and laboratory investigations, acute medical management, mandatory reporting obligations, multidisciplinary follow-up, long-term complications, and key medical mimics. This is a topic that directly impacts child safety. Let us begin. Case 1. A 4-month-old non-ambulatory infant is brought to the emergency department. Parents report the child fell from the couch. On physical examination, multiple bruises are observed on both cheeks, the upper torso, and back. The infant appears irritable but is otherwise alert. Parents deny any other trauma history. Which feature is most suggestive of non-accidental trauma? Option A, the infant's irritable behavior and alertness. Option B, the reported mechanism of falling from the couch. Option C, the location of bruises on the cheeks and torso. Option D, the parent's delay in seeking medical attention. The correct answer is option C, the location of the bruises on the torso and cheeks. Bruising on non-bony prominences, such as the torso and cheeks in young children, is highly suspicious for non-accidental trauma. A critically important clinical screening tool used in practice is the 10-4 Faces screening tool. This tool identifies two groups of high-risk bruising locations. The first group, called 10, stands for torso, ears, and neck in children under 4 years of age. Any bruise in these locations in a non-ambulatory child should immediately raise concern for non-accidental trauma. The second group, called faces, refers to the frenulum, angle of the jaw, cheeks, eyelids, subconjunctivae, or any pattern bruising. A 4-month-old infant cannot generate bruises on these areas through normal accidental activity, making the reported mechanism entirely inconsistent with the injuries found. Case 2. A 6-month-old infant presents with irritability and localized swelling of the distal femur. The parents report no known trauma. On examination, the infant cries when the leg is moved and appears to have pain with passive range of motion, which radiographic finding is highly specific for abusive injury. Option A, spiral fracture of the femoral shaft. Option B, classic metaphyseal lesion, also called a corner fracture. Option C, simple transverse fracture of the mid-femur. Option D, greenstick fracture of the distal femur. The correct answer is option B, classic metaphyseal lesion. Classic metaphyseal lesions are among the most highly specific radiographic findings for non-accidental trauma in infants and young children. These fractures occur at the metaphysis due to violent shaking or pulling forces that cause avulsion of the immature bone at the metaphyseal-diaphyseal junction. For key clinical points to find this injury, on anteroposterior radiographs, they appear as a bucket handle pattern. On lateral views, they appear as a corner fracture pattern. They are most commonly found at the distal femur, proximal tibia, and distal tibia. Their specificity for abusive trauma exceeds 95%. Making them one of the most reliable skeletal markers of non-accidental trauma in the pediatric age group. Case 3. A 5-month-old infant presents with lethargy and a bulging fontanelle. Which finding on dilated fundoscopic examination is most indicative of abusive head trauma? Option A, unilateral retinal hemorrhages. Option B, multilayered retinal hemorrhages with macular involvement. Option C, cotton wool spots. Option D, papilledema only. The correct answer is option B, extensive multilayered retinal hemorrhages. Multilayered retinal hemorrhages are highly specific for abusive head trauma in infants. The mechanism involves rapid acceleration-deceleration forces during a shaking episode that create vitreoretinal traction, causing vessels to rupture at different retinal layers simultaneously. This finding is rarely seen in accidental trauma or in other medical conditions, which makes it a crucial diagnostic indicator for non-accidental trauma. 3 key clinical indicators define this finding in the context of abusive head trauma. First, multiple retinal layers are involved, not just a single layer. Second, bilateral occurrence is common, though unilateral cases can also occur. Third, this finding is strongly associated with concurrent intracranial injury. Every infant with suspected abusive head trauma must undergo dilated fundoscopic examination by an ophthalmologist. Case 4. A 2-year-old child presents to the emergency department with burns on both lower extremities. Physical examination reveals sharply demarcated burn injuries extending from the feet to mid-thigh level. The burns show uniform depth without splash marks or irregular patterns. The child appears withdrawn and avoids eye contact. Parents report the child accidentally stepped into hot bath water. What is the most likely mechanism of this burn injury? Option A, accidental immersion in hot bath water. Option B, forced immersion burn representing non-accidental trauma. Option C, scalding from spilled hot liquid. Option D, contact burn from a hot surface. The correct answer is option B, forced immersion in hot liquid. Forced immersion burns create characteristic patterns that differ significantly from accidental scalds. 3 patterns are highly specific for non-accidental immersion burns. The first is the glove and stocking distribution, which occurs when extremities are forcibly held in hot liquid, creating sharp demarcation lines at the level of immersion. The second is the donut hole pattern, which shows sparing of skin areas that were pressed against cooler surfaces like the bottom of a bathtub, while surrounding areas show uniform burn depth. The third is the absence of splash marks or irregular burn borders. In accidental scalds, the child instinctively pulls away, creating irregular splash patterns and varying burn depths. The behavioral signs in this child, including withdrawal and avoidance of eye contact, also raise concern for chronic abuse. Case 5. A 4-month-old infant is brought to the emergency department following suspected abusive head trauma. Neuroimaging reveals bilateral subdural hemorrhages with evidence of bridging vein rupture. During a shaking episode, which physical force is primarily responsible for the rupture of bridging veins in an infant's brain? Option A, direct impact forces against the skull. Option B, rotational acceleration-deceleration forces. Option C, increased intracranial pressure from crying. Option D, compression forces from manual pressure. The correct answer is option B, rotational acceleration-deceleration forces. In abusive head trauma, the primary mechanism of injury involves rotational acceleration and deceleration forces applied to the infant's head. These forces cause the brain to move within the skull, creating shearing forces that tear the bridging veins and damage axonal connections throughout the white matter. For key anatomical factors make the infant brain particularly vulnerable to this mechanism. The brain moves independently within the skull during rapid head movement. Bridging veins tear due to differential movement between the brain and the skull. Axonal injury occurs throughout the brain as a result of widespread shearing forces. Infants are most vulnerable due to a combination of anatomical factors including high brain water content, incomplete myelination, and critically weak neck musculature that is unable to control or absorb the forces generated during shaking. Case 6. A 4-month-old infant sustains a traumatic brain injury from shaking that would likely cause minimal injury in a 4-year-old child subjected to the same mechanism. Why are infants under 1 year of age uniquely vulnerable to severe intracranial injury during non-accidental trauma? Option A. Infants have stronger neck muscles that create more rotational force. Option B. Larger head-to-body ratio and weaker neck musculature increase vulnerability. Option C. Infants have thicker skulls that concentrate impact forces. Option D. Decreased intracranial water content makes the brain more rigid. The correct answer is option B. Large head-to-body ratio and weak neck musculature. Infants are uniquely vulnerable to traumatic brain injury due to a combination of anatomical factors that distinguish them from older children and adults. The head comprises approximately 25% of total body weight in infants, compared to only 6% in adults. This anatomical imbalance, combined with weak cervical muscles that cannot stabilize the head, creates what is sometimes described as a bobblehead effect during acceleration-deceleration forces. For specific factors define this vulnerability. The head-to-body ratio is 1:4 in infants compared to 1:8 in adults. Cervical muscle strength is entirely inadequate for controlling head movement during trauma. Unfused cranial sutures allow greater relative brain movement within the skull. The higher water content of the infant brain increases the magnitude of shearing forces during acceleration. Case 7. A 3-month-old infant presents to the emergency department with irritability and feeding difficulties. The parents report the child fell from the couch yesterday. Physical examination reveals a well-appearing but irritable infant who cries when handled. There are no obvious external injuries, but there is high clinical suspicion for non-accidental trauma. What is the gold standard imaging protocol to identify occult fractures in this suspected abuse case? Option A. Single anteroposterior chest X-ray. Option B. Complete skeletal survey with dedicated views. Option C. Computed tomography scan of the entire body. Option D. Magnetic resonance imaging of the spine and extremities. The correct answer is option B. Complete skeletal survey with dedicated views. A comprehensive skeletal survey is the gold standard for detecting occult fractures in suspected non-accidental trauma. The survey must include a minimum of 21 specific radiographic views to adequately visualize all skeletal structures. A single babygram view is completely inadequate for this purpose because it cannot detect subtle metaphyseal lesions, rib fractures, or other injury patterns characteristic of child abuse. The essential views included in a complete skeletal survey are skull and anteroposterior and lateral projections, chest and anteroposterior and lateral projections, pelvis and anteroposterior projection, all four extremities in anteroposterior and lateral projections, the entire spine in anteroposterior and lateral projections, and dedicated views of both hands and feet. A repeat skeletal survey performed 2 weeks after the initial one can reveal additional healing fractures not visible on first imaging. Case 8. A 4-month-old infant presents to the emergency department with acute onset lethargy, poor feeding, and decreased responsiveness. Physical examination reveals a bulging anterior fontanelle and an absent Moro reflex. The caregiver reports no witnessed trauma, but non-accidental trauma is suspected based on clinical presentation. Which imaging modality is the most appropriate initial choice for detecting acute intracranial hemorrhage in this clinical scenario? Option A, magnetic resonance imaging of the brain with contrast. Option B, non-contrast computed tomography of the head. Option C, cranial ultrasound through the anterior fontanelle. Option D, skull radiographs in multiple views. The correct answer is option B, non-contrast computed tomography of the head. For acute neurological findings or suspected abusive head trauma, non-contrast computed tomography of the head is the recommended initial imaging modality. 3 key features make it the best first-line choice in this emergency context. It is highly sensitive for detecting acute intracranial hemorrhages, skull fractures, and cerebral edema, all of which require rapid identification in the acute setting. It is readily available in emergency departments and can be performed very quickly. It requires minimal or no sedation compared to magnetic resonance imaging in emergency settings. Although magnetic resonance imaging provides superior soft tissue detail and is essential for full injury characterization, it is used as a complementary study after stabilization rather than as the primary acute imaging tool. Skull radiographs and cranial ultrasound are inadequate for detecting the full spectrum of intracranial injuries in this scenario. Case 9. A 7-month-old infant presents with multiple bruises in various stages of healing on the arms, legs, and trunk, ranging from fresh red-purple lesions to older yellow-green ones. Parents report no significant trauma history. Physical examination reveals a well-appearing child with normal growth parameters. Which laboratory panel is most essential to rule out medical mimics of non-accidental trauma? Option A, complete blood count with differential and liver function tests. Option B, coagulation studies including prothrombin time, partial thromboplastin time, international normalized ratio, and platelet function tests. Option C, serum calcium, phosphorus, alkaline phosphatase, and vitamin D levels. Option D, thyroid function tests and inflammatory markers. The correct answer is option B, coagulation studies including prothrombin time, partial thromboplastin time, international normalized ratio, platelet count, and specific factor levels. When evaluating suspected non-accidental trauma with unusual bruising patterns, a comprehensive coagulation workup is essential to rule out underlying bleeding disorders that could mimic abuse. The combination of prothrombin time, partial thromboplastin time, platelet count, and specific factor levels provides the most complete assessment of hemostatic function. Conditions such as hemophilia A and B, von Willebrand disease, immune thrombocytopenic purpura, and other clotting factor deficiencies can all produce bruising patterns that may be mistaken for inflicted injury. It is critical that these medical mimics are systematically excluded before a diagnosis of non-accidental trauma is confirmed, while also recognizing that the presence of a bleeding disorder does not automatically exclude abuse. Case 10. A 4-month-old infant with suspected abusive head trauma presents to the emergency department. The child has a Glasgow Coma Scale score of 7, dilated pupils, and decerebrate posturing. Vital signs show bradycardia and hypertension. Computed tomography scan reveals diffuse cerebral edema with midline shift. What is the priority intervention for managing increased intracranial pressure in this critically ill infant? Option A, administer prophylactic antibiotics and obtain blood cultures. Option B, immediate intubation with hyperventilation and hyperosmolar therapy. Option C, schedule urgent neurosurgical consultation for craniotomy. Option D, initiate seizure prophylaxis with a phenytoin loading dose. The correct answer in this clinical scenario is immediate intubation combined with hyperosmolar therapy and seizure prophylaxis. The slide identifies this as hypertonic saline and seizure prophylaxis, which together address the two most urgent priorities. In severe abusive head trauma with signs of elevated intracranial pressure, the management approach targets 4 parallel priorities simultaneously. First, airway and ventilation must be secured immediately through intubation, with careful attention to carbon dioxide levels to avoid secondary brain injury. Second, hypertonic saline reduces cerebral edema by drawing fluid out of brain tissue through osmotic mechanisms and is the preferred first-line agent for intracranial pressure management in pediatric traumatic brain injury. Third, seizure prophylaxis is recommended due to the high incidence of early post-traumatic seizures in this population. Fourth, urgent neurosurgical consultation must be obtained in parallel to evaluate the need for surgical intervention, such as hematoma evacuation or intracranial pressure monitoring. Case 11. A physician is evaluating a 6-month-old infant brought to the emergency department with a femur fracture. The parents report the child rolled off the couch, but this mechanism is inconsistent with the child's developmental stage. Physical examination reveals additional concerning findings, including bruising on the torso and a healing rib fracture visible on chest X-ray. The physician has strong clinical suspicion of non-accidental trauma, but acknowledges there is no definitive proof. What is the legally required next step? Option A. Wait for additional evidence before taking action. Option B. Report suspected abuse to Child Protective Services immediately. Option C. Consult with the hospital legal department first. Option D. Obtain parental consent before proceeding with investigation. The correct answer is Option B. Report suspected abuse to Child Protective Services immediately. This is a non-negotiable legal and ethical obligation for all healthcare providers. 4 key principles govern mandatory reporting of suspected child abuse. First, healthcare providers are mandatory reporters with a legal obligation to report suspected child abuse. This obligation exists regardless of personal uncertainty or concern about family relationships. Second, the threshold is reasonable suspicion, not proof or certainty. The physician does not need to confirm that abuse occurred before making a report. Third, reports must be made immediately upon suspicion, typically within 24 to 48 hours, depending on local jurisdiction. Fourth, all documentation must be objective, factual, and include every relevant clinical finding. Physicians are legally protected from liability when reporting in good faith based on clinical findings. Failure to report is itself a legal violation in most jurisdictions worldwide. Case 12. A 14-month-old child who suffered non-accidental trauma is medically stable and being prepared for discharge from the hospital. The child protection team has completed their initial assessment. The parents have been cooperative with the investigation and have completed a parenting education program. Which component is most critical for ensuring the child's long-term safety and well-being? Option A. Scheduling routine pediatric follow-up appointments. Option B. Establishing a comprehensive safety plan with Child Protective Services. Option C. Providing parents with emergency contact numbers. Option D. Arranging physical therapy for developmental delays. The correct answer is Option B. Coordination with a multidisciplinary team to establish a comprehensive safety plan. Child protection requires a coordinated multidisciplinary intervention that extends well beyond the medical encounter. For essential team members must be involved in every case of confirmed or suspected non-accidental trauma. Social workers assess family dynamics and home safety and provide ongoing family support services. Law enforcement coordinates the criminal investigation in parallel with the medical and social work processes. Child advocacy centers provide specialized forensic interviews conducted in child-friendly environments and offer therapeutic services tailored to the needs of young trauma survivors. The medical team provides ongoing care, coordinates follow-up, and ensures complete and accurate documentation that may be required for legal proceedings. A safety plan that accounts for all of these dimensions is the single most important factor in preventing re-injury and ensuring the child's long-term protection. Case 13. A 15-month-old child who survived severe abusive head trauma at 6 months of age is being evaluated at a developmental follow-up clinic. The initial injury included subdural hematoma, diffuse axonal injury, and prolonged coma lasting 3 weeks. Parents are concerned about the child's developmental progress. What is the most common long-term morbidity associated with survivors of severe abusive head trauma? Option A. Seizure disorders requiring lifelong anticonvulsant therapy. Option B. Severe cognitive impairment and developmental delays. Option C. Progressive hydrocephalus requiring shunt placement. Option D, chronic visual impairment and cortical blindness. The correct answer is option B, developmental delay and permanent neurological impairment. Abusive head trauma is associated with devastating long-term neurological consequences. Studies consistently show that 80 to 90% of survivors develop significant neurodevelopmental impairments. The long-term outcome data is sobering and must be communicated honestly to families and used to guide rehabilitation planning. Epilepsy develops in 15 to 25% of survivors. Visual impairment or blindness occurs in 20 to 30%. Severe cognitive deficits affect 60 to 70% of survivors. Motor disabilities are seen in 40 to 50%. Behavioral disorders develop in 50 to 60% of survivors. Early intervention and comprehensive rehabilitation programs that include physical therapy, occupational therapy, speech and language therapy, and neuropsychological support can improve outcomes. But complete recovery is rare after severe abusive head trauma. Case 14. A 2-year-old toddler with a documented history of non-accidental trauma presents for routine follow-up. 6 months ago, the child sustained a physial fracture of the distal femur that was treated conservatively. The fracture has healed well on recent x-rays. The child is now walking normally and appears to be thriving in foster care. What long-term complication should the physician specifically monitor for during follow-up visits? Option A, osteomyelitis at the fracture site. Option B, growth plate arrest leading to limb length discrepancy. Option C, delayed union of the fracture. Option D, compartment syndrome. The correct answer is option B, growth arrest and angular limb deformity. Growth plate injuries sustained during non-accidental trauma frequently result in permanent long-term complications due to the severity and mechanism of the injury. Physial arrest occurs when trauma damages the growth plate's cellular architecture, leading to premature fusion and subsequent growth disturbances that manifest over months to years. For clinical pearls, guide the management of physial injuries in this context. Salter-Harris type 5 injuries, which involve axial compression of the growth plate, carry the highest risk for growth arrest and are also among the most difficult to detect on initial imaging. Angular deformities develop progressively over time and may not be apparent at the initial fracture visit. Long-term orthopedic monitoring is therefore essential for all children with physial fractures related to non-accidental trauma. Early orthopedic intervention, when indicated, may prevent the development of severe angular deformity or significant limb length discrepancy. Case 15. A 14-month-old child is brought to the emergency department after parents notice difficulty walking. Physical examination reveals multiple healing fractures of varying ages on skeletal survey. The child has distinctive blue sclerae, triangular facial features, and short stature. The parents deny any history of trauma and report that the child seems to fracture bones with minimal force. Which genetic condition must be differentiated from non-accidental trauma in this presentation? Option A, Ehlers-Danlos syndrome. Option B, osteogenesis imperfecta. Option C, rickets. Option D, leukemia. The correct answer is option B, osteogenesis imperfecta. This condition is the single most important medical mimic of non-accidental trauma involving skeletal injuries and must be systematically considered before confirming an abuse diagnosis. Multiple fractures in different healing stages combined with blue sclerae and a relevant family history strongly suggest osteogenesis imperfecta rather than non-accidental trauma. 4 red flags specific to osteogenesis imperfecta help differentiate it from abuse. Blue sclerae are present due to thin scleral collagen allowing the underlying choroid to show through. A positive family history of fragile bones or early deafness may be identified. Dentinogenesis imperfecta, presenting as yellowish or translucent teeth, may be present in certain subtypes. Radiographic features include gracile, thin cortex long bones, and Wormian bones in the skull. Genetic testing for collagen gene mutations can confirm the diagnosis. However, it is critically important to note that osteogenesis imperfecta does not exclude the possibility of coexisting abuse, and each case must be evaluated carefully on its own merits. Before we wrap up, we want to share an important resource with you. The Pediatric Case Review community on Patreon gives you access to a comprehensive, system-organized clinical education library. All lecture videos are systematically arranged by organ system, making focused learning efficient and accessible. Every presentation is also available as high-quality downloadable images for offline study and review. You will also find a comprehensive question bank with hundreds of case-based questions and detailed explanations to strengthen your clinical reasoning and prepare for board examinations. If you would like to join and get the subscription details, simply comment below this post, and we will message you directly. And that brings us to the end of today's comprehensive case-based review of non-accidental trauma in pediatrics. 5 core principles from this lecture should guide your clinical practice going forward. First, early recognition of non-accidental trauma requires high clinical suspicion and a systematic approach to every concerning presentation. Second, bruising patterns, injury mechanisms, and developmental appropriateness are critical assessment factors in every case. Third, a multidisciplinary approach that includes medicine, social work, law enforcement, and child advocacy ensures comprehensive care and child safety. Fourth, prompt and accurate reporting and documentation are not optional. They protect vulnerable children and fulfill your legal obligations. Fifth, long-term follow-up is essential to address ongoing medical, developmental, and safety needs. Please follow Pediatric Case Review for more comprehensive case-based presentations on pediatric topics. If you have questions or want to discuss specific cases, comment below and we will be happy to help.